You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Silvio Inzucchi, professor of medicine, the Yale School of Medicine, where he serves as clinical chief of endocrinology and medical director of the Yale Diabetes Center at Yale New Haven Hospital, New Haven, Connecticut. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Welcome to Medscape in Discussion. I'm Dr. Silvio Inzucchi. This is episode number 6, and we've saved the best for last. We'll be talking about newer therapies for type 2 diabetes. Early episodes covered treatment guidelines, effects on cardiovascular and renal outcomes with diabetes medications, obesity, and culturally competent care for minority populations. And today we're shifting the lens to look at promising future treatments. With me today to talk about this interesting topic is Dr. Joshua Neumiller. He is Vice Chair and Professor of Pharmacotherapy at the College of Pharmacy and Pharmaceutical Sciences at the Washington State University in Spokane, Washington. Josh is past Chief Editor of the ADA's Diabetes Spectrum Journal, as well as past Chair of the ADA's Professional Practice Committee, which is the committee that updates the American Diabetes Association's standards of medical care in diabetes each year. Josh is a clinical pharmacist and diabetes educator and works clinically in the home health setting. Welcome, Josh.
Yeah, thanks for having me, Silvio. It's a real pleasure.
I'm really looking forward to our discussion. So the topic today is newer type 2 diabetes treatments. Not that we need any newer treatments. I mean, last time I looked, there were 12 individual drug classes to manage type 2 diabetes. When I started out, Josh, we had 2. We had sulfonylureas and insulin, and metformin was just getting on the market. And the progress in this space has been dizzying over the past couple of decades. But here we are. And I don't think there's any less interest in developing newer and better therapies to pharmacologically manage diabetes. Before we start a discussion, how did you get interested in diabetes, and what do you find most interesting about the pharmacology of diabetes?
Yeah, thanks, Silvio. When I graduated pharmacy school, I actually thought I wanted to be a basic scientist, and I was on a path of trying to become an immunologist and work in drug development. And about a year into my postgraduate, post-PharmD training, I fell ill and was diagnosed with type 1 diabetes. And it just totally shifted my perspective, and going through that experience and realizing how overwhelming that was, even as a trained healthcare professional, really opened my eyes to the need for diabetes education and really educating people about how best to manage their condition. So it's been quite the opportunity, but it's really been amazing how many new agents are coming out all the time and all the new data. I think certainly the topics we're going to be discussing today are quite exciting as a pharmacist, just because of the unique pharmacology of these medications. I think another area that's really fascinating is something you've talked about in previous sessions, and that's the shift from the glucose-centric management to complications management.
It's a radical shift in how we've approached this condition. Well, let's start. I want to talk about insulins, 2 ends of the spectrum, ultra rapid and ultra slow. So these newer formulations of insulin, the first having a very rapid onset of action targeted at mealtime control of hyperglycemia, and the second being a new weekly insulin that's called icodec. And then we'll finish up with the so-called twincretin, which is a compound called tirzepatide. And there's some new and very interesting data from that perspective as well. Let's start with the ultra-rapid insulins. Can you speak to the need for this? I thought we had this down pat. Insulin Lispro, insulin aspart, which have been out for more than a decade now, were fast enough. Is there a need for even faster acting insulins?
Gosh, I guess we're always striving for matching normal physiology best we can. And that's where these insulins come in. They've taken rapid acting insulins and made some changes to the formulation to try and further speed up their absorption. And I think there might be specific individuals where there may be some advantages here, but I tend to agree with you, Silvio, that far and away, most individuals with type 2 diabetes, for example, I'm not sure there's a ton of added benefit for some of these ultra rapid agents, but there may be some folks who could draw some advantages.
I think the time course of action is maybe 5 or 10 minutes earlier. And so I think in a physiological study, if you're doing, clamps on study participants, you can discern a quicker effect. But in the clinics and in real world practice, it's not clear to me if that earlier time course of action is going to translate to anything significant. Certainly in the studies, there does not seem to be any beneficial effect on hemoglobin A1C.
Yeah, so in those trials in both type 1 and type 2 diabetes with both of the ultra rapid insulins, really no difference observed in A1C. Maybe where there's some potential advantage here is when they had different dosing strategies where they compared it to the original rapid acting, whether insulin aspart or insulin lispro, where they dosed both products at the beginning of the meal and then had sort of another arm where they allowed people to dose within 20 minutes after they started eating. I work a lot with older adults who maybe sit down to eat a plate of food, and if they're on rapid acting insulins, they're dosing before a meal. Sometimes their nutritional intake might be less predictable. And for those individuals, those are the few cases where I might, recommend some of these agents where they can dose it post meal.
These so-called closed loop systems. So for our listeners who don't recognize that terminology, these are insulin pumps that have been out for decades now. Married to glucose sensors, which have been out for probably about 10 years now or more, maybe. So the sensor is feeding glucose data to the pump, and the pump is determining the actual basal rate to provide to the patient. They tell me that the quicker the insulin action in those closed loop systems, the more physiological the system works. In other words, the better the control might be, because obviously you're dealing with two devices, and getting the pump to provide insulin rapidly in response to the glycemic excursions as determined by the sensor. To me, that makes sense. You want as rapid an insulin as possible, less in terms of the typical injections that many of our patients are still using. Would you agree that that may be the niche, shall we say, for these types of insulins?
Yeah, I totally agree, Silvio. I think those individuals who are on CGMs tends to be where I see patients asking the question as they're seeing a little bit of a postprandial spike, and their time in range may not be quite where they want it to be. Really thinking about adding on these agents to see if they can move the needle a little bit. In those trials, they did see some benefit on postprandial blood sugars, but as you mentioned, it's 10 to 20 milligrams per deciliter depending on the trials.
I do have a couple of patients that really swear by them, saying that they get better postprandial control. So there are two, I believe, on the market now. The first is a faster form of insulin aspart, and that's marketed as something called Fiasp. And that, I believe, has niacinamide in it. Is that like a vasodilator?
It is. It's a vasodilator. They add it in with insulin aspart, and it helps expedite that absorption to get that small increased rate of absorption for that insulin.
And the second is lispro, known as AABC lispro, which I'm totally unfamiliar with, those four letters. What do they mean?
Yeah, so the FDA, because we have all these new insulins coming out, and now we have additionally follow-on insulins and biosimilars, this is the new nomenclature that the FDA has added for biologic agents, where after about 2017 is when they proposed this nomenclature that agents approved after that point in time have to have this four-letter suffix that basically identifies that as a specific product. And, that's going to hopefully allow for pharmacovigilance, questions about immunogenicity with some of the biosimilars, so making sure they can follow and appropriately attribute any post-marketing reports to the correct insulin.
That's being marketed as Liumjev, I believe, and that's a combination of lispro and treprostinil and sodium citrate. Again, vasodilators?
Yeah, so vasodilation with the treprostinil, which is a prostacyclin analog, and then the citrate increases local vascular permeability to help speed absorption.
All right, let's switch to the other end of the spectrum. So Icodec is, this is still investigational. The ultra rapids are actually marketed now. So Icodec insulin is a weekly insulin. A weekly insulin, Josh. How can that be?
That's incredible.
I understand that the dose is 7 times the normal daily dose. So if somebody were taking, for instance, insulin glargine, 30 units per day or at night, that would translate to 7 times 30. So in that circumstance, it would be 210 units. That seems like an awfully big dose to start a patient on.
Yeah, I know the first time I heard about this, it definitely widened my eyes thinking about some of the implications for providers just coming on board with this particular approach. It's just such a different paradigm in high doses compared to where we're thinking about giving people in a single injection.
So this is obviously very slowly absorbed. The pharmacokinetic profile allows it to be given once a week. And there was a study in the New England Journal of Medicine about 2 years ago that compared it to glargine. So the glargine was started at 10 units at night. This is in a group of patients with type 2 diabetes that were suboptimally controlled. And then the comparator would be the Icodec at 70 units to start. And then the meds were titrated as we normally would. They had a specific protocol to do that. And surprisingly, the blood glucose data, the hemoglobin A1C, was almost identical, wasn't it?
Yeah, the A1C reduction was very comparable over the course of the trial after titration, of course. I went straight to the safety section of the paper to look at the hypoglycemia, which, there were really no increases in level 2 or level 3 hypoglycemia. And even the level 1, so blood sugar is less than 70, but above 54, not as big of an increase as, you might fear with such a long-acting insulin.
One of my concerns is, what do you do when patients are sick and are not eating? And, they may be predisposed to both hyperglycemia, depending on the nature of the illness, but also hypoglycemia if they're not eating. And what do you do when patients have surgery or hospitalized? What do you think is going to happen?
Gosh, I think that's going to be a huge question. And I think there's going to be a lot of work that's need to be done kind of in the real world setting to think about strategies for those individuals. Of course, maybe if it's planned procedures, there's some steps you can take, but unplanned hospitalization, they have insulin on board, and it's going to beg the question as to really how to manage those folks. Another interesting aspect of this, Silvio, is there was also a paper looking at switching insulin with this particular agent. And that one really was interesting because when they switched them from U100 insulin to this once weekly, they basically gave them also a loading dose, 100% loading dose for that first dose. So if it's, 70 units, they're converting, they gave them an initial 140 unit dose. Because this has such a long half-life, about a week, it takes a while for that to get to steady state. And I think there's going to be some early adopters for this insulin, but I think there's going to be some people that will need some convincing too.
It'll be interesting to see what develops. But again, that's still investigational, not yet marketed. Let's switch tracks, Josh. I wanted to talk about tirzepatide. Now, we've all become very familiar with the GLP-1 agonists. They've been out for a number of years now and are showing exciting data as regards to their cardiovascular benefits. So these are mostly injectables, although there is one oral formulation of semaglutide. And these agents reduce glucose by stimulating insulin secretion in a glucose-dependent fashion, but they also slow gastric emptying. They may suppress glucagon and also have an effect on appetite. So at least 3, if not 4 different effects. So powerfully effective glucose-lowering agents without significant increase in hypoglycemia, and again, maybe cardiovascular benefits. This tirzepatide molecule is very, very interesting. It is known as a twin incretin, as I alluded to before. Can you tell us a little bit about it?
Yeah, so as you said, this is a dual incretin agent. It activates both GLP-1 receptors, which, as you said, we're all familiar with. We have a lot of products on the market that are GLP-1 receptor agonists. This one's a little bit different because it hits one of our other incretin hormones and activates its receptors. That's GIP, or glucose-dependent insulinotropic polypeptide. I think there's some questions as to what this mixed effect is doing pharmacologically. Both incretin hormones, GLP-1 and GIP, stimulate insulin in a glucose-dependent fashion, as you mentioned. And GIP may also have some effects on lipid metabolism and some other factors that may play into its effects. But this particular agent, tirzepatide, is actually structured based on the GIP backbone. So this is a peptide-based agent, again, that will be injectable and really looking at once weekly administration here as well.
And some feel that it's really a very powerful GLP-1 agonist, that most of the efficacy data that we're going to be talking about in just a few minutes may be related to how powerful a GLP-1 agonist it is, that the GIP may be coming along for the ride, but how much that is playing a role in terms of the glucose reduction and the weight reduction is not entirely clear.
Yeah, definitely some questions here mechanistically, but the data looks really amazing.
Quite impressive. So there's a couple of studies I wanted to touch upon. The first was published in the Lancet last year in 2021. It's known as a SURPASS-1 study. So this is their foundational study in the clinic, phase 3, tirzepatide versus placebo, given to almost 500 patients with type 2 diabetes. Their hemoglobin A1C at baseline was about 8%. And they demonstrated powerful reductions in both A1C as well as in body weight. I think at the 15 milligram dose, the mean reduction was over 2%, wasn't it, for hemoglobin A1C?
It was.
And the weight effect was about 10 kilos. So now we're talking significant reductions in body weight of more than 20 pounds. I'm not sure about you, but I've had a lot of trouble getting type 2 diabetes patients to lose weight, and they do tend to respond less well to weight reducing medications than patients with simple obesity without type 2 diabetes.
Oh, definitely. Yeah. And so the weight loss is really quite impressive here. And even beyond the mean, we think about that 5% weight loss as an off-ramp for our anti-obesity medications. It was really impressive to me in this trial is when they looked at the percent of people who achieved at least a 5% weight loss, depending on the dose, it was between 65 to 80% of those participants receiving this agent. So it's really quite impressive.
And a lot were even achieving 10% weight loss.
Yeah, and greater. So
right.
It's pretty incredible.
Now, obviously, there's downsides to any pharmacological agent, and the Achilles heel, I think, of the GLP-1 agonists and also the GLP-1 GIP agonists would be GI side effects, right?
Absolutely. We definitely see the same effect with this. And as I think we'll talk about a little bit later, we do have some head-to-head studies where really looking at, a very similar nausea, vomiting, GI type side effect profile that we're accustomed to seeing with some of the more potent GLP-1 receptor agonists.
So obviously, slow titration is key when using these medications. So the study you alluded to is SURPASS-2. So this was a comparative study between, again, those 3 doses of tirzepatide, 5, 10, and 15 milligrams versus what many would consider best in class in terms of the GLP-1 agonist in terms of its efficacy data, semaglutide. And here, it looked like at the highest dose of tirzepatide, again, that dual GLP-1 GIP agonist was stronger than semaglutide at the 1 milligram dose.
Yeah, it was. It compared very well, statistically significant in terms of being a little bit better with the A1C reduction. But I think you made a key specification there that it is the semaglutide 1 milligram dose. We know that we can use it at higher doses for glucose lowering up to 2 milligrams, and also a little bit higher than that, up to 2.4 for weight loss. So it is important to kind of contextualize that with the data, I think.
So it would be interesting to see, and obviously the study was designed when the 1 milligram of semaglutide was the highest dose available. So it made sense to compare it to that. But since the study, SURPASS-2 I'm talking about, got underway, as you mentioned, there are higher doses of semaglutide available and now marketed. And the question is, what about a head-to-head study of tirzepatide at the 50 milligram dose, the highest, versus the optimal doses of semaglutide? It's hard to predict, what would happen with that kind of study, but it's quite extraordinary. I mean, I even heard that there was some top-line data released over the weekend in an obese population, non-diabetic obese population, using, again, tirzepatide, and they were reporting upwards of 50 pound weight loss as a mean. That's meaning that there's some patients that are probably losing 60 and 70 pounds. But that study has not been released yet, but there were some press releases from the company. But this is obviously a very, very exciting newer injectable agent, still not marketed, still investigational, and hopefully have access to that at some point. And hopefully the rest of the research portfolio for that compound will be relatively safe. Although again, whenever you're using these incretin agents, you have to go slow and be careful in terms of GI side effects. Well, Josh, it looks like we are out of time. We've covered a lot of ground today. We've talked about these newer ultra-rapid insulins, where their role might be. We discussed this new weekly insulin, which I think we both have a little discomfort with in terms of how we initially dose this medication and issues regarding hypoglycemia, although the data looked pretty good. And then we finished up with a discussion about tirzepatide, this new GLP-1 GIP agonist that is showing some impressive results, both on hemoglobin A1C in patients with type 2 diabetes and also body weight reduction, both in type 2 diabetes as well as in obesity. Did you want to pass any final thoughts to our listeners before we wrap up?
I just want to thank you, Silvio, for having me. A lot of exciting things happening. All these medications, I think, look very promising. We've highlighted some questions that will really determine how these are taken up in practice. For me, it really just comes down to making sure we're providing very efficient education to the people using these medications to make sure they use them appropriately, especially now that we're looking at, once weekly insulins potentially. And I think not only will the providers maybe have some apprehension, but there's a lot of opportunity for confusion with patients and caregivers too. So really thinking about some of those practical aspects of medication management.
Good point. Well, Dr. Joshua Neumiller, Vice Chair and Professor of Pharmacotherapy at Washington State University, thanks so much for joining me today.
Thank you, Dr. Inzucchi.
Thanks for listening. I'm Silvio Inzucchi for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Silvio Inzucchi. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on type 2 diabetes.